Hello and welcome to Westwind, an audio podcast about cancer, technology in medicine, and policy issues. I'm host and medical oncologist Dr. Jack West from the City of Hope Comprehensive Cancer Center in the Los Angeles area. You can find Westwind material at BeaconMedIC, oneword.com, at iTunes, or just about anywhere you get podcast content. I would just ask that you show your interest and support by subscribing, commenting, sharing by telling friends and colleagues in person and on social media, and rating it however you feel is appropriate. You can also share your ideas and opinions by emailing us at westwindpodcast@gmail.com. We'll continue our discussion now with Dr. Stacy Gray, who is Clinical Associate Professor at City of Hope Cancer Center in Los Angeles. We're now focusing on the challenges of broadening molecular testing beyond tertiary care centers and potential ways to make that scalable. Molecular oncology has changed the landscape of oncology practice and cancer care, but arguably one of the greatest challenges we face now is from falling short in what's actually being done in broad practice compared to what is known or considered as best practice by subspecialists working in the tertiary care centers in terms of molecular testing and then execution based on those tests. Do you have a sense, or have there been studies to speak well to the gulf that's there, or is this more imagined than real?
I think it's absolutely real. And there are a lot of data that support at least, if not documenting the gulf between what happens at tertiary care centers and community centers, but showing that when you look broadly, either population-based studies or large community studies, that we see that there's underutilization of many of the things that we know can benefit patients. So when we think about utilization of tumor testing to help guide lung cancer therapy, for example, we know that the rates of use of NCCN guideline-based testing is much lower than we would want it to be. Similarly, even if you identify mutations, about half of people who have identified mutations actually end up getting targeted therapy, so that's very problematic.
Yeah, really kind of mortifying.
Yeah, mortifying, right? I agree. And when it comes to testing people for inherited cancer susceptibility, we know not only that about half of the people who meet guidelines get tested, but actually, furthermore, that about half of the people who actually have mutations aren't even identified by the guidelines. So we have very large numbers of individuals who probably have high risk for cancer that are not identified now. And so I think that those are really significant gaps. And we also know that there are problems with interpretation of these data. And I've seen the most impressive studies in the germline or inherited cancer risk space that show that, up to 25 to 50% of surgeons misinterpret variants of uncertain significance and would offer more aggressive surgical intervention for people who have variants of uncertain significance, which really, by and large, should not be acted upon. So I think you are exactly right that there's a really large gap and that we need to figure out how to address that.
But at the same time, none of us was particularly well trained, or most of us were not particularly well trained to interpret the nuances of molecular oncology reports now. And I think that's really an issue. And working from a tertiary care center where there are a collection of molecular pathologists is one thing, but that's not what almost any general oncologist has been trained to do, nor is, I think, really well equipped to do. My concern is I don't think that the test reports make it particularly easy to understand what to do with that information.
And I completely agree. I think it is very difficult. The science is evolving so quickly, and the number of tests and the different ways in which we think about interpreting them and the nuances, it just changes so fast. So I think it's very hard for the practicing oncologist to keep up. And so, part of the work that we've done has looked at actually redesigning the molecular oncology reports so that they are more interactive and can be used at the point of care with embedded education as a potential way to do that. One of the things is that would require that the labs would be interested in really trying to engage the physicians and the clinicians who are using these data in a much more sort of consistent and ongoing way. I think that many people have argued for the addition of a molecular oncology sort of subspecialty, right? So that you have maybe somebody in between a pathologist and an oncologist where you actually would get a formal consult. And I think that there are centers that are moving toward that model because of the complexity. And then I think that we really need to think about how to engage patients in this whole process. And a lot of the work that we're doing is about trying to empower patients and provide them with the information in a way that they can understand and a way that will help educate them so that they can also advocate for the things that they need.
I think that's admirable, but I think we definitely need to be cautious about how to do that, because if oncologists are getting a 75-page report that includes a 2-page list of largely clinically irrelevant or unknown mutations, handing that to a patient is not particularly helpful. I think we really need to change how reporting is done to distill it down to this is an actionable result that has a standard of care treatment that you must follow. Here are some emerging data that have promising phase 2 data to go with it, even if it's not a standard of care now. And here are a bunch of findings that are not clinically relevant and represent rabbit holes to go down. And I mean, I'm just concerned about there are many potential errors of commission as well as omission here.
And I think that needs to be done for the providers as much as the patients, right?
Absolutely.
And so really making a clear distinction between what is actionable and what kinds of results have high quality evidence versus, as you're talking about, the rabbit holes where, there's theoretical evidence maybe in a mouse model or tissue culture, right? So, and I think we can do a better job with that.
Well, again, I think this is something where the molecular diagnostics companies have misaligned goals, and they're trying to justify a $6,000 test with a unfathomably complex report that, if you can't educate, obfuscate, and just that the complexity alone would seem to justify the more is better idea. And hey, try everolimus because it might work based on a mouse model. My grave concern is that oncologists and or patients who have internalized a concept that there must be a targeted therapy for every tumor might misinterpret that they should try that instead of a well-established but less glamorous standard of care that is chemo or immunotherapy.
Yeah, and I think that is, a potential tragedy, right? If something like that happens where somebody misinterprets or overreads or is hopeful that a targeted therapy that doesn't have clinical utility is used instead of standard of care therapy, whether it's chemotherapy or immunotherapy. And that it is, I think as a clinician, right, it's a challenging balancing act, right? When you have the promise of precision medicine, and precision medicine, I think, works very, very, very well for some people, right? And then you have patients who have a test and they don't have a targetable alteration, and that's devastating. It can be devastating for people. And so trying to walk that line as a clinician, I think, is very difficult, but being very clear in the reporting of genomic findings, what is actionable and what is not, I think, is something that needs to be done much, much more clearly. Now, I also will say that I think that, when you don't have a clear standard of therapy, or when you've gone through multiple lines of therapy and failed them, that those data, the uncertain findings, can be helpful sometimes, but again, it's very context dependent. And so getting the word out that that's really...
And I agree with that. I think that the issue is just, why is James Bond jump off the cliff when he's got a gun pointed at him point blank? Odds may be slim, but that beats a certain bad outcome. And so, but I think there's a difference between pursuing a big unknown as first-line therapy with a lot of established data for an alternative and trying it as a later line, eyes wide open, that your expectations need to be appropriate for the data to support
I
that.
completely agree. Yeah.
I would also say that, and I don't know what data there are or what's even begun to be studied, that there are issues with interpreting tests, but as you mentioned, these tests aren't done as consistently as we would like. That may be because there isn't enough tissue. Turnaround time is a major concern. And I'm just curious about what you know or what's being looked at for in terms of all of the potential pitfalls on the way to acting on a molecular oncology result, because the further you go from the tertiary care centers, very often there isn't much tissue. And I would say also, talking with many of my colleagues in community practice, they feel more pressure to start a person on treatment because the patient knows and may say, well, I'm just going to go across to your competitor. They'll give me chemo with immunotherapy tomorrow, like I saw on TV.
Right, right. So I think that there are a couple of systems level interventions that we could think about to try to really address those issues, because I think they are very real. So one is trying to make genomic testing more reflexive, right? So if you're a breast cancer patient and you have a biopsy or you have a surgical resection, right, every single person gets ER and HER2. It's just not, it's never a debate. It's something the pathologist does, right? And so within the pathology community, I think there is interest, as well as among many oncologists, trying to make testing reflexive when we know that there are FDA-approved therapies that can be used, right? It's different, right, because one is NGS and the other is, either immunohistochemistry or FISH. So there are problems in terms of ordering it, but those things seem to be things that we can address, right? So if you have reflexive testing, it could cut the turnaround time down by quite a bit if you can do it right when the sample is being first analyzed. The second thing, I think, and this is potentially harder, but trying to figure out ways to get larger biopsies. So if you're working with interventional radiology, trying to get larger biopsies so that we have more tissue. And then I think, as I'm sure you've talked about many times before, being able to use cell-free DNA assays as a way to try to get the answer quickly for people where treatment decisions need to be made right away. And so you could potentially think about doing it in a staged approach that way.
Well, I agree that cell-free DNA blood-based testing, that's broadly available, also has the benefit of getting results back faster.
Yeah.
And that is evolving as time goes on and is only becoming more reliable as an alternative. So that helps, yeah. Overall, do you think that oncologists, the broader medical community, and patients have been kind of oversold on the idea of precision medicine? My sense is that there's too much of a pervasive view that if you just squint at the NGS report long enough, you will find the hidden miracle treatment in there, or just the way it's marketed, that come get your tumor sequenced and we'll find the miracle treatment for you. And I'm afraid that that's going to ultimately be a disservice.
As I mentioned before, I think in some fields, right, non-small cell lung cancer, we really have transformed care for many people. So in certain areas, I don't think that there has been overhyping. I think the problem is that in other areas, for example, I had a patient who had head and neck cancer with whom I was speaking recently who said, this whole precision medicine thing is just really, a non-issue for patients like me. And it really bothers me that there's so much of a focus on precision medicine. So I think being really sensitive to the patient context is important. The hope, I think, is that we will continue to find more targets that we can treat, right? So with the new KRAS drug, we're opening up huge areas of potential therapeutic actionability that haven't been available before. So is there overhype? I think that in general, precision medicine has made a tremendous impact on oncology. So I don't think there's been overhype, but I do think that really attending to patients who don't have targetable alterations and going in and tempering expectations before testing's even done is one of the best ways to try to handle that.
I think your point's well taken, that it has been literally completely transformative for the beneficiaries thus far, and there are more every year or so. So that's been great. It's just that it doesn't apply to as many people as we'd hope. It would be great if it was universal.
Yeah.
Going back to your thoughts on potentially developing a specialty of precision medicine interpreter, that's not going to happen anytime immediately. Do you see a way to work on the scalability of interpreting precision medicine over the time frame that it's rolling into practice, as in now and over the next 2 to 5 years? Are there ways to implement precision medicine interpretation and make that broadly available to people who don't work at a tertiary care center with molecular pathologists?
I think that this is an area where we need a lot of creative thinking, right? And so one thing that we've discussed previously is whether or not there would be opportunities for crowdsourcing to be able to really tap into an international community of experts who could help guide things. There are also amazing online resources like My Cancer Genome and OncoKB, which if you can think about a way to incorporate the data that exists publicly, right, into decision support at the point of care. So I think, is there the potential that we could use crowdsourcing? Yes. Can we do much better decision support, particularly if we can get structured genomic data in the electronic health records so we can create decision rules? I think that would help a lot. There are many institutions that are moving toward pathways, and I think having genomically guided pathways is going to be essential. So there are things on the horizon. There are many companies that are growing up in this space to try to fill the gap. What exactly the perfect sort of set of solutions will be, I don't think anybody really knows at this point in time, but I think there are a lot of people working. And I think that, again, trying to think about some of the systems level kinds of things that have to do with the electronic health record are critical.
Mm-hmm. So overall, looking on the distant horizon, you are optimistic that in 5, 7, 10 years, molecular oncology will be rolled out and implemented, and we will have figured out ways to make it possible for people who are 200 miles or more from a big tertiary care center to avail themselves of those benefits, whether that is crowdsourced online content or sending that profile to some kind of Nighthawk service or whatever it is. Maybe it's the tertiary care centers offering a remote tumor board service, but some kind of implementation that you're hopeful will transform how we do things and makes molecular oncology synonymous with cancer care.
I'm very confident, that we will get there. I think that this is not a problem that is unique to molecular oncology, right? There are estimates that it takes 25 years to implement evidence-based care routinely into clinical practice, right? So this is not a molecular oncology problem by itself. I think that there are many aspects to molecular oncology that make it very challenging, but it's such an essential part of how we treat cancer now that I think that we have to do it, and we will do it.
Well, I want to thank you for taking the time, and I also want to thank you for studying something that I think is an actual real-world major problem that remains understudied, and the fact is what gets measured gets done. So we really can moan about it and speculate about how big a problem it is, or we can study the impact and try to address it directly. So I really appreciate your efforts in that regard. Great talking to you. I hope we continue the conversation in the coming years.
Thank you so much. It was a pleasure.
Thanks for listening. The West Wind Podcast is a Beacon Medical Interchange production with sound engineering and distribution by Mark Lindsay of Talking Speaker. We hope you'll be motivated to subscribe, whether at BeaconMedIC.com, through iTunes, or through another podcast service. Please also rate it, and I hope you'll be inclined to tell friends and colleagues in real life and on social media. We're always happy to get your suggestions and other input at westwindpodcast@gmail.com. Talk to you again soon.